people waiting too long. And that's kind of the classic MO of a lot of the people we work with, especially in the chronic ailments, with type 2 diabetes, hypertension leading to chronic kidney disease. So are you saying that like dialysis patients are waiting too long for these procedures? And what's that resulting in?
There's all sorts of complications and hospitalizations that happen if we don't get to the patients quickly and take good care of them. Mm-hmm. So we're trying to keep them out of the hospitals, basically. Mm-hmm. Mm-hmm. So we have a great team of interventionalists and surgeons that try to optimize the access so that we can avoid those problems. Also get catheters out the same day or next day. They tend to wait a long time. Mm-hmm. And then, for instance, Dr. Posner is able to do surgeries typically within 2 weeks. It depends on how the whole process goes. But the standard of care seems like 4 to 6 months to get a fistula created.
Wow.
And so we've reduced that, kind of like Amazon would, to 2 weeks. So when somebody comes into the dialysis center, new catheter, new admit, we try to get that patient to get an ultrasound to scan the veins within a day or two and to see the surgeon within a few days.
So the tech's role is then to notice these things, to evaluate.
Absolutely.
To bring it to the attention of the nurse, and then the nurse will then make that endorsement to the nephrologist who would make the referral. Is that right?
That's the way it's supposed to be.
Yes. Referrals come from the doctor. They don't tend to come from the techs or the nurses, right. Or at least that's the way that it should be.
So I'm going to go in a little different direction, which is the insurance companies. The insurance companies are very fragmented. They really are not honed in on what they need to do for patient care to improve results, etc. So a lot of these patients, one of our critical things is to get catheters out and get fistulas created quickly. And if the insurance companies aren't getting their job done effectively, it makes it difficult.
Mission
Every
impossible.
dialysis unit or people I talk to is complaining about this insurance, that insurance, or this insurance. And so that needs to be worked out. Our insurance companies are not getting to the point that we can help these patients well.
That makes sense. So there's a bottleneck on approvals or on the clearance of reimbursement. Is that what it is?
I'd say just organizations, and it could be done much more efficiently.
Yeah.
You're listening to Musings with Morales. Brought to you by Dialysis Education Services.
4th edition of Musings with Morales. I'm Morales. Yeah, so thanks for joining us, guys. We started this podcast about a month ago. We've been plotting it out, and I'd say probably more than 15 years since I met Paco, who's producing the podcast. It's been like, hey, you gotta find a way to really cast a broad net to people. Like, the whole reason I started as a dialysis educator years ago was to really broaden my net and broaden my reach to where when I taught people, hopefully I could impart on them some of my knowledge, skills, abilities, but really the passion that I have for the patients, right? So we started this thing with really an intent on reaching different audiences, those that hopefully we can help people prevent the preventable with type 2 diabetes, hypertension, obesity, which leads to the chronic kidney disease and failure. And then 2, for those that are within those stages of different points of kidney failure, there is also a lot of touch points with healthcare professionals. We train dialysis technicians and nurses, and we really want to impart on them kind of an interdisciplinary, intersubjective scope so that they really can form opinions, form best practices. And then also to the patients that are watching us, that they would find authoritative knowledge base, but also some real talk in certain cases. And I think this is a great group to have some real talk. So I want to introduce the 3 guests we have with us today. These are really passionate, knowledgeable, expert group of interventionalists and vascular surgeons. First, we've got a longtime friend of mine, Dr. Anthony Becker, who's an interventional radiologist, a local business owner, business partner, physician, and subject matter expert, very close to Dialysis Education Services. Has offered a lot of support over the years. And thank you, Dr. Becker, for joining us and actually bringing along some of your colleagues, some new acquaintances of mine now, and glad to meet you both. First, we've got Dr. Steve Posner, who's also a board-certified vascular surgeon. And then last but not least, we've got Dr. Dipak Ranparia, who has certifications in interventional radiology and diagnostic radiology. And forgive me, guys, if I've missed any of the accolades or the acronyms behind your name. But again, thank you for joining us today. I think we've got an audience base that could really benefit from the conversation that we'll have tonight, and I think it's something that they would not want to miss. So again, thank you all for joining us. I'd like to just dive right in to the expertise of each of you, because as I read through some of the biographies and then some of your online just descriptions of business and reviews and things like this, I wanted to hear it directly from you. Dr. Becker, you're the longest acquaintance with me. Let's start with you and kind of go, where are you at today? What is your expertise? And you did specifically point out some topic that you felt like you'd be the best person of this group to speak to as far as a one-stop shop with what you're doing at Azura in Long Beach. So could you share a little with us?
Mike, thanks for having us. I'm the medical director at the Azura Long Beach Ambulatory Surgical Center, where we're focused on reducing the time to care, increasing the access and quality of care. So that's our main focus.
Thank you. So when you say reducing like the timeline to care, what exactly do you mean by that?
So
and why is it so important to be reducing the time where patients are getting vascular care, interventional procedures, or even startup procedures?
So every day we have 1 or 2 physicians working depending on the demand. Most days 2, a surgeon, maybe an IR, interventional radiologist, so we can plow through the cases very effectively. These patients tend to wait too long to get procedures done, and so we try to do it the same day or the next day.
So, that's something that, aside from vascular preservation, creation, something that's really something you said there is people waiting too long. And that's kind of the classic MO of a lot of the people we work with, especially in the chronic ailments, with type 2 diabetes, hypertension leading to chronic kidney disease. So are you saying that like dialysis patients are waiting too long for these procedures? And what's that resulting in?
There's all sorts of complications and hospitalizations that happen if we don't get to the patients quickly and take good care of them. So we're trying to keep them out of the hospitals, basically. So we have a great team of interventionalists and surgeons that try to optimize the access so that we can avoid those problems. Also get catheters out the same day or next day. They tend to wait a long time. And then, for instance, Dr. Posner is able to do surgeries typically within 2 weeks. It depends on how the whole process goes. But the standard of care it seems like 4 to 6 months to get a fistula created.
Wow.
And so we've reduced that, kind of like Amazon would, to 2 weeks. So when somebody comes into the dialysis center, new catheter, new admit, we try to get that patient to get an ultrasound to scan the veins within a day or 2 and to see the surgeon within a few days.
So before we got started tonight, you asked about ultrasound. Is that the vessel mapping we're talking about? The vein mapping?
I was actually referring to using it to access.
Okay, to actually perform the cannulations.
I mean, we have an ultrasound lab in our office, so when patients come, they can be scanned same day to get their vein mapping done, which is a prerequisite to doing the surgery.
Right. Thank you, Dr. Becker. So I think the focus of your input today's discussion is really going to be that expeditious service and how that impacts the quality of life, the quality of care, life itself for individuals that need these procedures.
And access to care. For instance, we're open on Saturdays. There's no one else in the region that's open on Saturdays. So we're trying to reduce the costs, increase the access to care, and speed up the delivery time.
Wonderful. Dr. Posner, so I see that you're very proud, and we've heard kind of the accolades of the day prior to getting started here, but surgical fistula creation, workup times, time to maturation. So it sounds like fistula creation as really the gold standard in access is what you're focused on?
Well, as opposed to AV graft insertion, sure.
Yeah.
I mean, absolutely. Of the 120 cases I've done in the past 4 months, I've put in 1 graft.
Wow.
So they're all vein cases. The patients get referred to us, and once I see them in the office, the process is fairly fast because this is all I do now. I used to be in a general vascular surgery practice, did carotids and aortas and bypasses and a lot of limb salvage and a lot of dialysis access. Now I'm just devoted to doing the dialysis access.
Wow.
So patients see me, and then within a few weeks, they're in the operating room. So they see me, I work them up in the office, we'll do a vein mapping in the office. If they have any overriding health issues that have to be sorted out, we'll send them for clearance, but that's maybe 3 or 4% of the population that have to go for clearance because all of our procedures are done under local anesthetic with sedation or a shoulder block. So we don't need to put them to sleep, and because we don't need to put them to sleep, we can take care of some fairly sick patients in the outpatient setting. Once the access is created, I'll see them back in the office about 2 weeks later, and then I'll see them every 3 to 4 weeks after that until I feel that their access is ready to go. So for the first 100 cases, about 65% of them were ready to go between 4 and 6 weeks out. About 80% were ready to use between 6 and 8 weeks out, and the other 20% longer than that.
What's ideal, Dr. Posner, for the actual use of a fistula? And when I say ideal, what's the definition of ideal?
Well, I mean, in terms of
uses?
ideal, you want something that's about the size of a number 2 pencil because you want the text to be able to access it easily. You want it to be thick-walled, and you want it to be scarred in a little bit. So we never let them access anything prior to 4 weeks after surgery because that vein has to mature, it has to thicken, and it has to grow in size. So, I mean, ideally we'd start them between 4 and 6 weeks, but some patients simply take longer than that. Their veins take longer to dilate. If that vein hasn't dilated by about 8 weeks out, I'm usually sending them for interventions to help them along. If when I examine them, I feel that there's something wrong with it, that it's pulsatile, I think there's an area of narrowing, I may scan it and then send them for a procedure to open it up.
I definitely have more questions in that regard as far as maturity and what's being found in the field, and how they get back to you guys at the center. Dr. Ranparia, you've got some unique accolades as far as when I was able to find of you online and kind of what Dr. Becker presented to me. It looks like you're working. Is it on the endo fistula type of access?
There's a relatively new procedure where you can create a AV fistula just through needle holes now. This is more taking foot. There's a better foothold in Europe about this, but it's come over to the United States, and there are lots of centers around the United States that are doing this now. I think the gold standard for fistula creation is still surgery, but there's a definite place for endovenous creation of AVFs. They're very poor surgical candidates. Some patients that just don't want to have surgery for whatever reason. And so this is a good option for that.
So the indications, at least from what I just heard from you, is the fear of the surgery and the invasiveness of it, and then when you say like the vascular candidacy, like what are the details there as far as an indication?
Well, like Dr. Posner was saying, he's actually been with the ability to do blocks on patients' arms. It's not quite the same as sometimes in a hospital setting where you need a lot more clearance, to clear the heart, clear the lungs before you can get a surgery. He's able to do many more patients than maybe at a hospital setting. And so, anybody that he can't do, I am more than happy to do.
But just to jump in for a sec, so in terms of patients who are not suitable candidates for an ASC, these are the patients who can't lay flat without being short of breath, who had a heart attack 6 weeks ago, who have multiple medical illnesses that just, you look at that patient and say, I should not be doing this in the outpatient setting.
Got you.
And those patients we tend to bring to the hospital, but You know, when I was routinely doing access in the hospital, the anesthesiologist would require clearance of most patients, and it really backed things up quite a bit. And for patients who are having a procedure with an 1.5 inch long incision under local anesthetic with sedation, you just don't need to get clearance on them.
Yeah.
And that really held things up a lot in the hospital.
So that's what really revolutionized how creations are done now.
Mm-hmm. But it makes sense now in context when you talk about the shortened time to actually achieving either an intervention or an actual creation, why one of the ambulatory centers is a much faster route. Is that uniform, Dr. Becker, that the times that you all are seeing with your practices is, should we expect that uniformly across similar type of organizations?
Yeah, so the reason why we're doing this is because there's a there's a high catheter rate in the dialysis centers, excessively high.
Yeah.
And so we're trying to reduce that.
What's the problem with catheters?
Catheters they cause infections, hospitalizations, etc., that drive up the cost. And
you're looking at me like, why are you asking me that?
Yeah, you know all the answers, but they increase the mortality and etc. of patient care. So all the incentives are now to get these patients' catheters out, and so the dialysis centers are under tremendous pressure to do that. They're in the LA area. It's probably 25% or so of the centers, and it should be about 10%.
Oh wow!
So the reason why we're aggressively trying to reduce these catheters is it's necessary for better patient care.
Yeah,
I mean, it's not just infection. A lot of these catheters, they are constantly hitting the wall of the superior vena cava. They cause scarring on the inside. That scarring leads to a lot of problems,
Can we? I love that. When we think about those problems as a dialysis tech in the past, the catheter can have an effect and cause, like, on the same limb side, if you've got a fistula or a graft in the future, recirculation, stenosis, things like this. What else are we talking about?
Some patients, there's a subset of patients that would rather have the catheter, it's because they don't really fully understand the mechanics of everything. And, I think if they understood all the complications, which infection is also a big one.
Yeah.
So when patients come to me, oftentimes they'll say, why can't I simply keep the catheter? And I explain that there are 3 reasons why catheters are bad. One reason is there's a high infection rate, which can put you in the hospital. It can also infect the heart valves, and you could need open heart surgery to fix that. And it increases the cost of care. It increases the amount of time spent in a hospital setting. The second reason is dialysis through a catheter is not efficient. The 2 holes, the holes from which you pull the blood out and the hole which you put the blood back in, are right next to one another. So you tend to get a lot of recirculation in the catheters, which means that you're cleaning blood that you've already cleaned. Yeah. So it's not efficient dialysis. And the third reason that I cite is what Tony and Dipak have said, that you tend to get central venous scarring around the catheters. Yeah. And that's something which you can't fix. It will keep coming back over and over and over again. And it causes major problems.
Yeah. So let's shift a little bit. Let's go back some years. And today I actually spoke to a group of high school students locally here in Bellflower. They're in a career pathways type of program, trying to decide what they're going to do. Some of them, others are like, I know what I'm going to do. I want to be a nurse. I want to be an ultrasound tech. These are some of the things that came out today, right? And, I thought to myself, like, where was I at when I was in high school? And it was clearly like, I knew how to do dialysis. I mentioned that I did it at home with my uncle, right? I knew how to do that. I could have done dialysis right out of high school as a tech. I was like, no, I don't want to do that. I went and did construction for a few years and then had like the call of the wild and decided, like, okay, I know how to do it. I'm pretty good at it. I understand it, and ended up working in dialysis clinics. I quickly found out that it wasn't a job. It was a profession. It was really a calling for me, kind of circumstantially in life, that, like, I have to do this. And I feel good when I do it. I don't feel like I'm working when I do it, right? I can truly say that I enjoy what I've been doing for the last 25 years. It brings me a sense of purpose, fulfillment. I am able to build others with me. So I'm curious, you guys go back to high school or to college at a point where maybe this wasn't what you were going to do. How did you get here, and what sunk in the passion for you, if you can speak to that? Let's start with Dr. Posner.
Well, coming out of high school, I had no idea what I wanted to do. I went to college and I got a liberal arts education. And toward the end of college, I was trying to figure out what to do. I actually took the LSAT, which is the law school exam. Did well in the LSAT and sat down to write applications and realized that I really didn't want to be a lawyer. And at the same time, a friend was was the teaching assistant for a comparative animal physiology course, which he convinced me to take, and I loved it. And it sort of went from there. From there, I went to med school, and in terms of the type of surgery I'm doing, I was always interested in doing vascular surgery. I trained in general surgery, and then I was fortunate enough to do a vascular surgery fellowship, and here I am 20 some odd years later.
Tell me about the joy, the fulfillment, the sense of purpose with what you're doing today, the contributions that you've given to the community as a whole, but and dive into the dialysis community as well.
Well, I mean, I like surgery because I can do something concrete to help somebody. Internal medicine is a wonderful field, but watching someone's high blood pressure for 20 odd years and tinkering with their meds is something that needs to be done, but not up my alley. I like doing something that makes a difference that I can do with my hands.
Got you.
I like making a difference for patients. When I was in general vascular surgery practice, I did a lot of limb salvage work, and that was extremely rewarding and extremely challenging. With dialysis, it's much the same. I mean, it's very rewarding to give someone access to life-saving therapy and give them a reliable access that will last them. And then being able to send them to my colleagues to keep that access running, it's fulfilling.
Thank you. Dr. Ranparia, same question.
Yeah, I think I've always known that I wanted to go into medicine. Ever since I was a young boy, my parents took me to India. I met my grandfather there. He had these very dense cataracts, and I was probably in 6th grade at the time. It's like there's so many things I wanted to do to help him because, just the cataracts and other medical problems were affecting his life negatively. And so I think I always wanted to go into medicine because of that. I went through med school and found a love for surgery. I entered into a urology residency program at first and actually loved that, but found that interventional radiology was actually even more interesting. They were doing, you can help different disease processes all over the body. And I used to do a lot of that when I was in Nashville, embolizing tumors and stopping bleeding from different places. Dialysis work is a nice subset of interventional radiology because you can open up arteries, you can declot fistulas. We place catheters like the peritoneal dialysis catheters.
Doesn't seem too boring, huh?
No, it's not boring at all.
Different day every day, huh?
Yeah.
Yeah, very, very good. Dr. Becker, how about you? What's the roadmap or the journey that brought you to the great guy that you are today?
Mine is more simple. My father was a neuroradiologist in Torrance Memorial, and his best friends were mostly radiologists. Many of them invented the sheaths, etc., that we use today. So they loved what they were doing, and they showed a lot of enthusiasm for it. As I went along in residency, I spent my first day, I remember in interventional radiology, and I just loved it. It was better than reading films all day. So that I kept on going on that pathway. And I think Dipak and I have had this same experience in our professional careers, where we've seen the ways to do things properly and the ways to do things improperly.
Yeah.
And we felt we can improve the system. And that's what we're trying to do now at Long Beach.
Yeah.
Is get it's in Bellflower, but basically to do the right things to help patients out, reduce costs, and improve outcomes.
Yeah.
So,
It seems to be the trend for the last, I don't know, since probably 2010, the do more with less, right? At least, especially in the dialysis reimbursement world, is, everything got bundled, and really everybody thought that dialysis was over at that point, right? But we shifted, and we actually improve outcomes with less reimbursement, although there's less choices.
More ethical care.
there's better practices and guidelines. For instance, we don't place bare stents at our center. We only place covered stents. We go by
When
KDOQ
necessary.
guidelines when necessary. But if we have to put a stent in, we only place covered stents. So there are things that we can do to improve outcomes.
Gotcha. So I'm curious, guys. Thank you for sharing the personal journeys. I think it means a lot, and every time I talk to an aspiring healthcare professional, it's like I wonder where they're going to be in 10 years, right? We teach techs and nurses at Dialysis Education Services, but we've had people come out that turned into doctors, that turned into administrators, into educators, things like this. And I got to tell you, till I met you, I did not know what an interventional radiologist was. Honestly, working in dialysis all these years, I didn't know what an interventional radiologist was. It was truly enlightening to meet you, Dr. Becker, and then to be able to visit the center and watch some of the procedures that you guys do. Look forward to more people like you opening those doors and showing people what happens behind the scenes. Access preservation is something that I've really keyed in since meeting you, Dr. Becker. But let's go to a couple just quick questions, like kind of rapid fire type of stuff. There are a lot of myths out there in life, right? Like I grew up in a Hispanic family, so I could tell you like a billion myths on healthcare, right? And then my wife, she's Filipino, but she anytime me or my son are sick, she puts Vicks on our feet and puts socks on our feet, right? Vicks on your foot and socks, and that's going to cure everything, right? But I'm curious, like you've worked with a lot of people, whether it's interventional radiologists, vascular surgeons, nurses, nephrologists, dialysis technicians. Are there any funny myths out there, or any myths that you could bust right now and say like that is not true?
Basically, we're collaborating together, which is unique in our field. Surgeons and interventional radiologists typically fight for cases.
Okay.
And so maybe it's a myth that we can actually get along. I have a problem.
It's a unique situation, and it works very well where we are.
Yeah, if I have a problem and say Dr. Posner is in the center, I'll tell him to come in and say, does this need surgery? What's the story? And we can collaborate. And same thing with Dr. Ranparia. We'll consult with each other. It's a friendly, we're all together for the right cause. I was just going to talk to different facility administrators at dialysis centers at a conference, basically. And they were in very wealthy neighborhoods. I'm not going to point out the hospital in the area, but they're having the highest catheter rates were in some of the best parts of Los Angeles.
Wow.
And it was because the surgeons and the radiologists and the ultrasound department, they're all fighting for the patients.
Yeah, that's unfortunate.
And so we are. You bring the patient in, they get a catheter, you come to us, we work it up, and we get it done in 2 weeks. We're not competing. So I think it's not a myth, but it's just a better solution is a collaborative approach.
It brings the question to my mind, are there specialists that are either perceiving or preaching that I have all the answers and I have, the whole solution is in my hand. I don't need the interventional radiologist. I don't need the interventional vascular surgeon, or that there's a missing piece there?
I'm not sure that there is that, but I think that there's a lot of competition out there for the wrong reasons.
Yeah.
And some of them are financial. And so the critical thing is to focus on the patient's outcomes and to do it as a team. So teamwork is critical with all of us.
Yeah. Fistula maturity. I got to ask this. Squeezing the ball, is it my fault that my fistula doesn't mature if I don't squeeze the ball?
So squeezing the ball. The general idea of a squeeze ball works best for forearm veins, I think, not really the upper arm veins, because the forearm veins are the ones that when you're squeezing the ball, you get an increase in flow through them. And that does help these veins to mature. In terms of the ball that you should use, it should be something that's soft foam, not hard foam, not a baseball. It should be something soft. So I tell patients that if they don't have a soft foam squeeze ball, they can simply roll up an old washcloth and use that. But something that you can actually squeeze through.
Yeah.
If fistulas don't mature, no, it's not their fault. I mean, it's some veins mature, some veins don't mature. These veins that we use, some start very, very small, and some are large right out of the gate. The ones that are large right out of the gate, those are the ones that we tend to start using at 4 weeks, 5 weeks, 6 weeks. The small ones take longer than that, and it takes a while for those to mature. And as I said before, if they're not maturing, we can then send those for balloon-assisted maturation, which means that we'll go in with the procedure and we'll tweak that vein a little bit larger. And sometimes it takes 2 or 3 sessions like that to get the vein to a size where we want it. If you go too large the first time, you'll rupture the vein.
Right.
So you dilate the vein, you allow that to heal for a while, and then you can dilate the vein a little bit farther. And that's very effective in getting poorly maturing fistulas to become useful.
Anything to add to that, Dr. Ranparia?
Well, I was going to say, you're talking about the myths before. Patients, one thing they don't like are aneurysms, the aneurysms that get big.
Yeah.
And those aneurysms can be prevented. And I don't think patients know that.
Yeah.
It's basic. Most of the aneurysms are due to blockages upstream. And it's just a matter of injecting contrast, finding the blockage, and then opening that, usually with the balloon. It's usually a 5-10 minute procedure. And aneurysms can be prevented.
Right. So good point. I actually got a chance to see a few of those with you, Dr. Becker, and I remember you saying, like, we're only going to use this size of a balloon because we can't go up to this size just overnight, right? We've got to do some sort of gradual progression. So yeah, there are some myths out there for sure around vascular access, right?
I got another one for you. So some patients, when they come in, they have the impression that when I create access in them, there are tubes hanging out of them. Everything's underneath the skin. So the tube that we use is their own vein in general. We can also use a plastic tube called a graft. The problem with the grafts, though, is they're more prone to infection and clotting off.
Right.
So we try and use their own veins.
Right.
But all I'm doing is creating a connection between the vein and the artery being the higher pressure blood vessel. Once I make that connection, the higher pressure blood from the artery is going to flow through that vein and make that vein larger over time, and that's what they'll use for access. But there's not any kind of plastic hanging out of them.
So here's another one for, I think, specifically for you, Dr. Ranparia. Sorry, but it brought to my mind, okay, myths. I've heard many people on the chronic hemodialysis floors discourage peritoneal dialysis because the catheter is going to get infected, according to them. So what are your thoughts around risk versus benefit on a peritoneal dialysis catheter?
Well, okay, so, just end-stage renal disease in general, a kidney transplant is the best option. But of course, there's limited amount of kidneys and limited amount of transplant surgeons. And so I think only about a third of end-stage renal disease patients actually get a kidney transplant. So the rest of them have to have dialysis somehow.
Yep.
There's peritoneal dialysis, fistula creation, and then catheters. Catheters is clearly the poorest of those options. Peritoneal dialysis is very good for younger patients, for patients who can hook up themselves and handle a little bit more of their own medical care. They hook up every night and use their peritoneum as to do the dialysis. The fistula for hemodialysis is the second best option, and of course, you have to go into the dialysis unit 3 times a week. Of course, there is home hemodialysis also, but fistulas are also a good option.
Let's dive into home, Dr. Ranparia, since you brought it up. Home hemo, you got the peritoneal, which is like full self-care, right? Or assisted by a care partner type of care. Home hemo is very underutilized, and you kind of mentioned, you got to go into the center, right, for hemodialysis. Most people, that's what they do. I grew up with somebody that in the 70s was doing it on his own at home, hemodialysis, right, which is almost still unheard of in today's statistics, right? So let's go to self-canulation, because that seems to be a big barrier in home dialysis utilization in the United States. Of somehow these needles got to get in these patients' arms, right? And we already know the complications or the problems we have with professionals putting needles in dialysis patients' arms. Now we've got trained but not professionally trained individuals, the patient themselves or their care partner, putting needles in their arms. Do you guys have any lens on that from where you're at in vascular preservation, health, creation, on tips, some advice on how to really improve this
Well,
situation?
I guess there have been these buttonhole ways to cannulate.
Yep.
Maybe Steve might be able to better.
So for home hemo, for home hemo, my understanding of it is that they get buttonholes created in the dialysis center, which means that you stick the same place 3, 4, 5 sessions in a row, and you start forming a scar track at 2 sites. And once you form that scar track, there's a small scab that forms. And when you do home hemo, you actually use a blunt needle rather than a sharp needle, and you just sort of take off the scab at the top, and it slides in.
That's already a ready-made track for the
ready-made
needle to
track,
drop in.
exactly.
Yeah.
So it's easier to access it, and it's safer cannulation, you could say, than doing it at the hemodialysis center, where you may have rotating techs who don't know that particular fistula, who are using sharp needles,
Right.
who can cause harm.
Right. Yeah.
So someone who has a good fistula with good buttonholes, who has the wherewithal to put the needles in themselves, is a great option.
So let's go to another quick. We didn't sit so quick on that one, the myth busting, right? But let's go to daily habits. Dr. Becker, we've talked about the field collection of data, assessment, the 1-minute checks, these sort of things. Aside from that, or maybe expanding on that, what are some daily habits that are important to vascular access preservation, whether it's on the patient side or it's on the people that are actually out there touching them? And one of the things I always say is, when they're in the center, like, who's touching the access the most? Like, I always want to point the finger at myself if there are issues with a vascular access in the center.
So I think one of the most important things that people need to be educated on is the physical examination. So it's really, I work with hundreds of nephrologists over the years, and very few of them are experts at doing a physical examination. And most of them rarely do a physical examination. It's something that is important to be doing. So we need to train people to do that. So how do we do that? We have people come into the center, whether it's your students or people in the dialysis unit, to do a physical exam, see an angiogram, and then do a physical exam afterwards. The dialysis data is somewhat unreliable. So I try to teach people to learn physical exam, all the different findings, the signs and symptoms, and then later the dialysis information.
Yeah, I've asked you the question before. What's the best tool in identifying the need for an intervention, right? And is the answer still the same? Is it that physical
I think
assessment?
it's physical exam. Transonics isn't readily available everywhere, and it's expensive, so people don't invest in the companies don't invest in it. But
I try to get patients to feel for their thrill. That's the most important thing. Is they need a nice thrill over the beginning part of their fistula. Their fistula should be, if they have aneurysms, the fistula should be soft, not hard. Hard usually indicates that there's back pressure from stenosis or something.
So are you saying that, like, one of the rules that I've tried to live by is that I want to impart to the patient that what I do when I check your access, like, you should also be doing at home. Is that
Every day, I tell them they should be feeling it every day. And if there's something off, they need to either bring it up to the dialysis center or to their doctor or to me, whoever.
So when should that? So let's say I'm sleeping, right, and I'm sleeping on my fistula, and I wake up at 11:30 p.m. and there's no thrill. Like, what am I supposed to do at that point?
Well, at 11:30 at night, probably not much. Probably the best way to handle that is at your next dialysis session, see what the technician says. If they agree that it's clotted, then they would come to a center like mine, and we'd probably have to do a declot procedure at that point.
Is there ever a time where waiting until the next dialysis session is too long, or?
Well, I would say that if they notice a change, for instance, they lose a thrill, they lose a pulse, they don't think it's open anymore, they should, first thing in the morning, contact their provider, and they could be sent for an ultrasound, could be sent directly to the surgeon or the interventional center. The sooner we do the declot, the easier it is to do, because the clot hasn't hardened up yet. And it just makes it easier. And also that way, if they're identified early, they don't necessarily have to skip any dialysis sessions. And they also, that way, can stay out of the hospital.
Yeah. Do you guys still see, and I don't know if this would happen in your centers, but I used to work in a professional building that was right next to a hospital locally here. And patient would, come in, we'd do the physical examination. They'd, there's no thrill, there's no bruit. We'd call the hospital. They'd get over to the hospital. They'd come back tonight with a fixed access, right? With a couple of catheters in their arm or cannulas in their arm, and
stitches.
Was maybe even a drip of, I think at that point, saline. They either did what? Is it thrombolysis or thrombectomy? Is that what we're looking at when they clot up?
I'd say when they still have catheters in their arm when they come back.
Yeah.
That's unusual.
Yeah, I'm not quite sure about that.
Well, they'd come back, but the point is, like, there was actually technicians who would stick then feel like, oh, it's clotted.
Right.
And a couple of occasions, the patient would go next door and they'd come back with this nurse that was really PO'd, right? And it was like, who stuck this person? You guys need to go back to school, blah, 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 this sort of thing, right? They bled all over the place when we're doing the procedure.
Is this hospital-based more?
It was next door to a hospital.
Next door. I think it's not a myth really, but today most of these procedures are done outpatient unless they're high risk. And so that's a big change.
Yeah.
So rarely do you see anything like that. We won't leave a sheath in or anything like that. They'll go back with the functioning fistula and get catheterized.
So let's go back to the past again and just give a piece of advice to Dipak Ranparia, when he was sure he wanted to do this but wasn't doing it yet. What would be your best piece of advice to either avoid some pitfalls or find some more and have a good time doing it?
Well, I think the most important thing is to be true to the patient. That's the most important thing. Do what's best for the patient. Treat them like they're your family.
Yeah.
I think a lot of doctors, unfortunately, get caught up with finances, and it's. I think somewhere along the line they kind of lose that. We're really here for the patient.
Yeah. Well, I think that's great. Where he just says, don't lose it, right? Because nobody started out with that. I don't think, anyways, with that as their purpose. I hope that people don't get into healthcare because they're trying to stack their vault, right? They're trying to help people They have a purpose behind the skill set, behind their hands in the case of surgeons. How about you, Dr. Posner?
Like the people you work with.
Like the people. All right. So can you?
Yes. I like the people I work with. I was in a practice for 20 years that after 20 years you start to form disagreements with people. It happens over time.
Yeah.
So I'm happy for the change, and I really like the people I work with now, and work collegially with people as well.
So would you? I want to open that up a little bit because I've done a few things in my life, and there are points where what was is not what is. The original culture, the original mission of an organization, the original just execution of the mission by the individuals involved. Is there a point where it's like, I got to call it and I got to cut my losses here and move on to like in your case here, you're saying, you've moved on to a new partnership or into a new venture.
Yes.
Do we have to be hyper conscious of that as healthcare professionals? You as a physician, do we have to be hyper conscious of when the end of the road with that engagement, or when we're not aligning with what's going on with where we're at?
I think that's going to be a little bit different for each person.
No.
And the important thing is to be true to yourself.
No.
Do the ethical thing, and if you find that you can't do either of those two things in the situation that you're in, then you should move on.
How about you, Dr. Becker?
We just try to make things simple. As Dr. Ranparia said, we try to treat patients like they're our family. We try to practice by best guidelines and best practices, meaning we don't do things just for profit. And at the same time, we practice as though we're paying for the procedures, meaning we know somebody's paying us, and we do what they would want us to be doing,
Right.
not to run up a big bill or whatnot.
Yeah. I think stewardship is kind of what I heard here, the level of accountability that we have as professionals towards the main stakeholder, but also the stakeholders as a whole. So again, shifting topics, just a couple trending topics right now. Healthcare is in a pretty big uproar with shortages across the board, right? I'm not sure how the landscape looks on the physician level, the surgeon level, the interventional radiologists. Are you guys seeing the same sort of shortages in your discipline, or is it among the nurses and the peripherals to the practice? Are you guys hit as hard as the rest of the industry is?
I'll just start and let them go. I mean, we've been fortunate that we have a large number of high-quality physicians that have joined us, like Dr. Ranparia. How many months ago was it you joined?
3
or 4. But we have a really strong group of physicians that have joined. Dr. Posner went from his practice. One of his reasons was he actually thought that the nursing and the tech care and our front desk was quite amazing. I think that contributed to you wanting to leave the hospital and go to a situation where we can run 2 rooms with really great people.
Staffing shortages? What do you guys? Is it
That's
That's
been a problem for the last several years, since COVID, certainly. Nursing shortages, tech shortages, people either aren't going into the field or they're leaving the field, demanding more money. The hospitals have a smaller profit margin. They're actually losing more money because staffing is so expensive right now. In terms of the doctors, I don't think it's changed that much as of yet, but doctors sort of go through cycles. There'll be cycles where there's a shortage of OBs, and then lots of people go into OB, and now there are too many OBs. So I haven't really seen those issues doctor-wise, but staffing-wise, absolutely. It's been a huge problem, finding good qualified staff.
Do you feel like the recent challenges that we have with staffing, like you mentioned the wage index, kind of moving next door for a nickel. I would say even I've noticed some change in work ethic over the recent years.
Sure.
What you get for what you pay is much different than it was, I'll say, like even 3 years ago. But is it having an impact on care? Are you seeing more people in your facilities and procedures because of a lack of eyes on the patient, a lack of time to do the actual physical examinations?
I think at Long Beach we're kind of unique that we base all the staff that we have are internally sourced. We haven't gone out and really recruited most of the staff, so we've been very fortunate to have a really great group of people. And there's a lot of people that nurses and techs that want to leave the hospital setting. They're tired of call. They're tired of all the variety of things that weigh on them and make it toxic in a hospital, which we just don't have outpatient.
Yeah, much different.
So it's a different environment for us at Long Beach.
But I want to digress again. Like, are you seeing more referral as a result of the lack of care in these dialysis centers?
I think it's really hard to say because, I mean, we see patients all the time that have ulcerations that they've had for months and months and months and haven't been sent over, or they've had high pressures for months and haven't been sent over, and now they're clotted, or now they have huge aneurysms. But that's been the case forever. Patients coming in with problems, and it's really hard to tease out if that's something which is increased or not.
And training too. So one of our goals is to get people in to train from the dialysis units, and it's really hard. So people can come in for free and train with us Monday through Saturday. So it's more of a training issue, I think, than actually anything else.
I'll tell you, we've taken advantage of that, and thank you so much.
I really like to teach the patient. I mean, I think that would be the best person to know when there's a problem.
Yeah.
So I usually spend a lot of time, make pictures to show what we did, to show them why they had whatever problem why they had the prolonged bleeding. And I think if they're the first ones who can know that there's a problem, but obviously there's the alarms and the dialysis machine going off.
What I tend to tell them is that at least once a month they should ask their tech, how are my pressures? How's my clearance?
Define what you mean by pressures.
Sure. So there are arterial pressures and venous pressures when you're on hemodialysis. The arterial pressures are how hard you have to, or what kind of pressure is coming in through the line that's taking the blood out.
Okay.
And the venous pressure is when you put the blood back in, is that going in at high pressure, which it shouldn't be. The pressure should be fairly low because it should be a low resistance outflow from that vein.
Okay.
And when you start to see those pressures rise, that's an indication that there's some kind of narrowing forming up above. Because as it narrows down up above, you have that pressure can't get through and it tends to build up in the axis, which can then cause ulcerations. It can cause aneurysmal change. It can cause recirculation.
Yeah.
So they should also ask about recirculation. So pressures, recirculation, clearance. So if they do that once a month, it just helps keep them on track, because sometimes the techs don't send them when there are those problems. And if they're asking about those issues, then that reminds the techs to
send them.
I want to tap on that because I've heard it, I think, 2 or 3 times now that the techs send them. So, okay.
No,
I want to just
to clarify.
Be very clear about
Sure.
that. Like, how does that referral go? If I'm the tech on the floor and I'm doing an examination or collecting some data on the patient, and I find a starting of an aneurysm, I find when I'm listening to the access, I hear a whistling sound or maybe an absence of any sound at all, called the bruit, right? Like, what am I supposed to do as a tech in a clinic?
My understanding is the first thing is you show to the charge nurse. The charge nurse can confirm those findings. And if those findings are real, that there can be a referral made to the nephrologist who would make a referral to our center.
Gotcha.
That's the way it's supposed
Yes,
to be.
referrals come from the doctor. They don't tend to come from the techs or the nurses,
Right.
or at least that's the way that it should be.
So the tech's role is then to notice these things, to evaluate,
Absolutely.
to bring it to the attention of the nurse, and then the nurse will then make that endorsement to the nephrologist who would make the referral. Is that right?
I mean, just as an aside, everybody who has these fistulas, almost everybody, 90%, will eventually get some sort of scarring. And there's, a few reasons for this. One, you're connecting a vein which has a very thin wall to an artery, this vein is now seeing a very fast pulsatile flow. That it's not really made to see that flow.
Yeah.
It kind of builds up over time, but during that build-up process, the hemodynamics are different. There's turbulence. The turbulent flow causes little micro tears on the inside lining, and then that heals by scarring. So basically, everybody gets scarring. It just happens. It's a matter of when, 3 months, 6 months, a year.
Yeah, it's kind of a drastic difference, some patients to the other, right?
Yeah,
I mean,
absolutely.
like I mentioned, my uncle's, I remember, I don't know, 5 or 6 years old, swimming in the pool, and he was swimming, and his hand was down like this, and he's got this baby's arm on top of his arm, right? Literally, it's like a snake, right? And I used to like to put my head up to it. I can remember this very vividly. Put my head up to it and listen to the bees inside of the snake. That's what I was listening to. The thrill, right? I could actually hear it if I would put my ear up to it. It's a fun memory, actually. Yeah, fun memory. We're in a pretty volatile, critical point as far as the workforce and being able to get those referrals done. Like, I've been to the clinics. Some of the things that I've done as a consultant is even on-site audits of practice in preparation for surveys or in response to like multiple deficiencies. Some of those revolving around access, and you've talked to me about this before, but these physical examinations are not happening in a lot of cases. So again, it just makes me wonder about the throughput in facilities like your all's. Are we seeing an increase because of the shortage? Is there an impact on care? Obviously, with wait times, there's an impact on care. We know there's a correlation to mortality with catheters being left in longer, right? So I think something for us to ponder on. I'd definitely like to hear you guys, hear the input on how this is affecting you as time goes on, because it's not getting any better. The nursing shortage in the United States is massive. The dialysis technician shortage in the United States is actually pretty massive as well, especially here in
So at the
California.
dialysis unit, yes, there definitely is a shortage across the board.
And that's what I'm saying is if they're not able in some cases to do their job because of how thinly
Well, they
they're
have
being
so many.
stretched.
Yeah, they have so many patients to see, and so they just go boom, 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 boom.
Yes. It's like cookie cutter assembly line type of things happening a lot of times. So even more important why, groups like yours opening their doors to show the before, the during, the after, and how to prevent them from getting to those doors. Now, one thing I want to ask is, they come to you, they get either the start or they got an interventional procedure like these balloons, right? These angioplasties, right?
Angioplasty.
I think at one time, Dr. Becker, you had told me that it's now like you got a routine cadence to your visit. Is that true that like once they've had that plasty that they need to be seen periodically and possibly have some other interventional procedures, or like is it the end
There's
of the
going to be
line?
a recurrence rate, and everybody's different.
Mm-hmm.
What we try to do is bring them back or make a recommendation to bring them back based on prior images, seeing what we did, and what our experience tells us when they probably are going to come back. Because we don't want them to grow aneurysms, clot up, or have other problems. So we'll make a recommendation. What we currently do is expect the dialysis unit to follow up on that with our front desk at about that time and determine whether there's a change in the physical exam, signs and symptoms, or dialysis data to suggest that the patient needs to come back and there's medical necessity. And then we get a referral, if so, from the dialysis unit.
From the nephrologist.
Yeah, dialysis
From the
unit
nephrologist.
Years ago, I visited one of your centers, and there were some people around. They were actually employees of the dialysis organizations, and they had some sort of title, like a vascular access champion or something along these lines. Managers. Are there still dialysis techs or nurses out there serving that role to make sure that these referrals and these these follow-ups are happening in a healthy cadence, or is it kind of up to the best
Most of the
practices?
dialysis companies have vascular access managers. There's a lack of education and coordination and expertise from our side going into the instruction of those people. They're hired and they have their own training programs, which are somewhat superficial compared to what we should be doing with them to train them. Yeah.
You know, kind of going to that education, it's something it's what keeps me up at night, you know, is being able to impart something that somebody's going to use, whether it's a patient, whether it's a professional, whether it's somebody that doesn't know the first thing, like when I went today to talk to these high school students, didn't know anything about kidney failure according to them, but as we got into it, 2 of them had family members that were dialysis patients, right? So, you know, like I said, that keeps me up at night. It's really my purpose is trying to impart. I don't want to hold what I know. So are there things in your personal life aside from like today and then Dr. Becker, I can know just the invitation of the community and schools into the center. Are there things that you guys are doing to educate from a mass perspective, like that, to evangelize the cause here of vascular integrity, vascular preservation, vascular access, or maybe it's even prevention of these vascular type of comorbidities that are leading to chronic kidney disease?
Well, I mean, we will go into different dialysis centers and answer any questions, teach whatever we can. My main purpose, I think, is to work on the individual on the patient level.
Yeah. Hard to think about the mass when you've got like the responsibility of so many people.
We always have our doors open to anybody, any dialysis techs, nurses that want to come in and observe
So
what
everybody's
we're doing.
here in Long Beach Bellflower office, right?
Yeah.
As far as the practices.
Yeah.
How about you, Dr. Posner? Any evangelism today?
Well, there's evangelism every day when I meet patients in the office. I mean, when I first see them, I talk about the process and what I'll be creating in them and what the function is and how it works. I also spend some time talking to dialysis center staff and administrators and my referring nephrologists. I think education is powerful.
Yeah.
So the more info you have, the better.
Dr. Becker.
I'm going to go in a little different direction, which is the insurance companies. The insurance companies are very fragmented. They really are not honed in on what they need to do for patient care to improve results, etc. So a lot of these patients, one of our critical things is to get catheters out and get fistulas created quickly. And if the insurance companies aren't getting their job done effectively, it makes it difficult.
Mission
Every
impossible.
dialysis unit or people I talk to is complaining about this insurance, that insurance, or this insurance. And so that needs to be worked out. Our insurance companies are not getting to the point that we can help these patients well.
That makes sense. So there's a bottleneck on approvals or on the clearance of reimbursement. Is that what it is?
I'd say just the organizations lack the knowledge or desire to get this done effectively. And it could be done much more efficiently.
Yeah. I kind of like to end every time we do one of these podcasts and really, take a moment to reflect. Let's think about who could be watching this. The same people that we just talked about, the one-on-ones, right? People who it matters to most that actually depend on these vascular accesses to sustain life. Those that are caring for them, and then also your colleagues that are in the same profession or maybe even aspiring. So I would say, to each of you, take a minute, but if you could speak to all or one of those groups and just kind of leave one last thought of inspiration, what's the most powerful message that you can leave to all or one of those groups today? Again, take your time to think about it. I'm pondering right now on the collaborative point that you made, Dr. Becker, of doing what's right for the patient, not holding any one piece of the equation to myself, but calling on help. And as I heard about the power of education, one of the things that has been a core value of mine is really embracing interdisciplinary care and interdisciplinary education or intersubjective data. So, what I took tonight is this collaboration that you all have, the collaboration that you have with the patients, the collaboration that you have even with the payers and having to evangelize and speak and advocate for what's right for the patient, that intersubjectivity, that interdisciplinary approach, that it's on point, and that it's something that I want to share with the audience, that you got to keep listening to different voices, you got to keep seeking out information, you got to find experts and people that are passionate about what they do. So anybody want to lead that one off?
I'll just start with we want to continue to improve access to care while reducing costs and improving quality. And there's a ton of things that we can do in terms of those goals. And we just need to simplify the process and get we have dialysis companies, insurers, the patients, the providers, a lot of people to get on board to do that, to simplify it.
Yeah,
So-
that's truly an evangelistic mission that you've got right there. A lot of people to get across, a lot of people to educate. Dr. Ranparia?
Yeah. Again, I'm speaking to the patient. I mean, this fistula is your lifeline.
Yeah.
You are the best person to take care of your fistula. So you need to know everything about it and what's going on with it.
That's solid. Yeah, 100% agree with that. I grew up with it, and it makes me think about a patient that she wasn't my patient, but somebody I'd met along the way. She had a graft that eventually she got a transplant, but she had that graft in use for 9 years, and I was like, what? I've never seen a graft last 9 years, and I was like, what's your secret? And she was like, well, I know, what I'm supposed to be looking for. I look at it every day, and I also know what everybody's capabilities are, and I don't let people touch me who shouldn't be touching me. Just struck a chord with you.
What I'll often say to my patients, which pisses off the hemodialysis centers, is you should have one regular tech and one alternate only.
Right.
You should not have rotating techs, because that's when you have problems. You get a couple people that learn your access, learn how deep it is, learn what angle to put the needles in.
Yeah.
That's what you want.
Yeah.
And it's super important. The other thing that I'd impart is, if there's a problem with your access, come see someone.
Yeah. Yeah.
I mean, ulcerations are not normal.
Right.
Ulceration should not go for weeks and months. If you have an ulceration, come and see someone.
Let's crush the myth of the aneurysm as well, because we touched on it for a second, but aneurysms are not normal part of access, are they?
Yes and no. I mean, aneurysms form in a lot of accesses, and they don't necessarily have to have upstream stenoses to form. I think that it certainly makes them form a lot faster, and you can reduce the speed at which they progress if you address those upstream narrowings. But patients think that it's something abnormal, or it's something that's put in the arm, and it's just a natural process of you stick the access over and over and over at the same site, and you're going to get some dilation of that wall.
Yeah.
And it happens very commonly. It can be slowed down.
Yeah.
Yeah, so ideally, if they rotate where they're accessing, that's another way to
Preserve it much longer, or prevent
aneurysm.
Yeah.
So the rate of the growth of an aneurysm, the equation basically is the radius squared. So it grows exponentially the bigger it gets. So prevent it from getting bigger.
Yeah.
And then times the pressure. So keep the pressure down on the access, which is reducing. When the stenosis comes back to basically angioplasty or whatever you have to do to keep the pressure down, and it goes 1 over the skin thickness. So you want to make sure that you're not thinning the skin out too much by puncturing the same site, or when an aneurysm grows, you're destroying the elasticity in the wall of the vessel, so you want to make sure you're not destroying that.
Yeah.
So those are the 3 things that are going to contribute.
Yeah. Hey, guys, I really enjoyed the conversation today. I think we touched on a lot of things that are the basics, but also modeling that is unique to today. As far as the ambulatory centers and the speed at which things can be done in these centers. I really appreciate it again. Thank you, everybody.
Sure. Thanks, Mike.
Thank you, Michael. A pleasure to meet you. Thank you.
Thanks.
This episode has been brought to you by Dialysis Education Services.